topic for today. Topic for today is ovarian assessment, and before I go to the topic, we have around 88 people logged in, more are joining. So I'll go to the backgrounder of 𝐼𝐶EAT. What does 𝐼𝐶EAT stand for? 𝐼𝐶EAT is nothing but we want to uncomplicate our lives. This is our the the take-home message we give to people is that we have to uncomplicate ourselves. That's the reason you come to us. And this is a pyramid I repeat in every class. Why I repeat it is a reason that for all of us, this pyramid looks quite nice, but what lies behind the pyramid is that we learn maximum by practicing and by teaching. So you all of you are here. I really appreciate your the efforts and the motivation to be with us at 8 o'clock in the morning. Not many people can do it. So the very fact you are here today morning, I mean, you're all having your breakfast and cup of tea, that proves beyond any contention that you are very keen to learn and very keen to teach too. So we should practice what we are learning. We are discussing today and then we'll be teaching others. So that's the way we can get the maximum information from what we are going to learn today. This is about an average student. This is somebody like me. I always say that, but for somebody who's brilliant, I mean, they can always do it better. So this was an old era which we had, where we had to type everything, and we used to go to the libraries to get information. But now there is on internet, so many webinars are happening every day. So now press of a button, we have the knowledge. But knowledge to hai, but knowledge ka interpretation kya hai? This is what we're gonna teach today. Once every day there is a webinar on ovarian reserve testing. So people say, how are you different? What you're gonna teach to people? We'll go to YouTube and learn. I said, okay, go to YouTube and learn. YouTube is something very, very nice. Even I go to YouTube to learn. So now coming to the topic is that we are presently stuck in a maze. We actually, when we talk about ovarian reserve testing, we hardly know ovary. We know our hearts. We know our liver and kidney more than our ovary. Ovary is one organ about which we are not taught, and we never want to learn also. We only get stuck with ovary and the only thing which we know about ovary is that we remove an ovary. When we are doing an hysterectomy, we remove an ovary. But now let's see the whole of ovarian reserve testing. It's like this maze. We don't know from where to enter, where to go. So my endeavor with you today, we'll have to make an inroad so that all of you follow the same protocol. We have a lot of our alumnus joining. I can see a lot of you here already. Some are new friends we are making today. We'll give you a clear pathway to move towards a good clinical diagnosis, so where we can manage. So we're gonna today, with the help of the Zoom platform, we'll be giving you some information, some tips on this digital platform. This video, you can take down your notes, and after this, it will be also available on our virtual university in case you subscribe to it. So a few of the courses which we are doing, we are having courses on 𝐓𝐞𝐬𝐞𝐫, IVF, we have courses on andrology, we have our courses on ultrasound. So every part of IVF is covered in our hybrid training courses. And we have a virtual university where you can enroll. It's a pretty cheap one where you can get all these things which we teach, which are not taught in our courses, is available here. It's an addendum to our courses. We have some YouTube channels which you can subscribe, and you can actually, and they're not meant to subscribing to me or anyone. They are subscribing to information. In case you go to our courses, you'll have case report sort of things where you learn how to counsel the people who come to you, say with poor ovarian reserve or with multiple problems. You learn how to talk to them. We have an embryology YouTube channel you can subscribe to and learn few good tips and tricks. We have COVID scholarships available. So in case you know somebody who wants to learn but cannot afford, somebody very poor who cannot afford to pay, we have got scholarships. We call them COVID scholarships. You can tell them, they can approach us, and the whole course will be free for them. These scholarships are part of our CSR, and we have in every category, we normally tend to give 1 or 2 seats to people. We have a resonance series, which are pretty good ones to read. And we take out a series booklet, small booklet every 15 days to 3 weeks. So we have got large number of them already printed. They are available on the net, or you can approach us. We'll be giving it to you. You can take from us. And just to keep, so we have from IUI to genomics, we have covered nearly every topic. Coming to the curtain raisers, this was always a burning issue in my mind. I always thought how to get knowledge to all of you in a very simple way, different from webinar sort of a training. So the first curtain raiser which we had was on, I think in 1st of November, we had the first curtain raiser. We picked up a topic. We normally pick up a very abstract topic, and which has got a multifunctional approach. So we picked up plastics. Then we had one on microscopes in whole of ART lab. So microscopes were covered very well appreciated. That gave us a lot of confidence, and then we shifted to air quality in an IVF lab, a very well appreciated curtain raiser again. We had one topic like OPU needles in IVF, about which people didn't know. Then we had one on embryo transfer catheters. So we pick up the topics which are not given in the books that easily. Then gradually, on approach, a lot of people came to us. So then we wanted to shift it to having some common topics like IUI, protocol for beginners. Then we spoke on ultrasound and ultrasound physics and application. We had a curtain raiser on gonadotropins, luteal phase defect, azoospermias. We had another one on IUI tips and tricks, more refined one. We have one on adjuvants, HSG, reproductive endocrinology, and next one is on endometriosis. So we'll be meeting again on 10th of October with one on endometriosis, and today is on ovarian reserve assessment. So in the coming 45 minutes, I'm going to take you to school days and talk to you about ovarian reserve testing, ovarian reserve testing. So this figure, we are quite well aware of that when we used to read a long time back, that in our body we have the whole menstrual cycle going on in the woman, and then we have different levels of hormones going up and down. So we have an FSH in the beginning, then we have initially we have E2 brings FSH, and then we have LH, then progesterone coming. This thing we have covered in the last curtain raiser on 15th of August for nearly 1.5 hours. So all our curtain raisers are building up one upon another. So I won't go to this now. But one thing is for sure, that what we realize is that in case you really want to learn about ovarian reserve testing, we have to understand the menstrual cycle. Because this will tell us in case all the hormones are going up and down like a symphony, then all these hormones will be in the right order. This is one thing which we have to understand. And then comes the very complicated concept which connects the hypothalamus somewhere here and the ovary. They both are now interconnected and they both talk to each other. So both ovaries and hypothalamus talk to each other. And how do they talk to each other? They don't have a mobile phone to say hi. They basically talk on some chemical messengers. So they talk on basis of certain hormones, and they are like, they work on negative or positive feedback, and that's the way they communicate. There's a positive or negative feedback occurring, so hormones keep coming up and down. And in case the feedbacks occur properly, then we can be sure that we have good ovarian reserve. Because in case the adequate hormones are coming in adequate amplitude and frequency, we can be very, very definite that ovaries are working well. So keeping that in mind, we'll understand the basic concept of hypothalamus and pituitary today in very short. I won't take much of your time. So we have to know something about AMH, which comes from the ovary. We need to know about Inhibin B. We'll talk about estradiol. We'll talk about FSH. Probably we'll talk about some amount of LH and P4, which comes from the various parts of the body. And then we'll move ahead. And we have to know that in the ovary, in case we take an ovary and cut this section of the cortex, in case we take the ovarian cortex, here is the medulla. But this is a very important concept I'm going to tell you now. This is not given in the books. Even if given, we are not able to comprehend them. So this is it. Ovarian cortex has got multiple types of oocytes. They are at different age of growth. So we have a primordial follicle. Basically, they are the oogonia. Then we have primary follicle. Then we have pre-enteral follicle, Small antral follicle, large antral follicle. So confusing. Then we have pre-ovulatory follicle, then we have a ruptured follicle, we have a corpus luteum, and then the whole journey starts again. So I'm going to talk to you about the journey. This is very important for me. But this was my past around 15 to 18 years back or 20 years back. When the whole of ovarian reserve testing, the mapping of the uterus, endometrium was done by doing a DNC. Every OPD, we used to do some DNC, some curettages. Then we used to date the endometrium, but it's in early follicular phase, late luteal phase, where it lies. And based upon that, we were giving the treatment to people. And as you can see very beautifully here, that in the early follicular phase, we have low estrogen. So FSH starts rising here, and that is reflected. And we have low progesterone here. So everything is being reflected. I won't talk in detail about this because it's outdated. But I think in case you have somebody as antique as me in the audience today, they will agree with me that doing the endometrial biopsy was a very important part of our armamentarium when we were trying to treat a patient who was having infertility. So moving ahead of this, ovarian reserve testing, which we call as ORT, we call it ovarian reserve testing, is directly proportional to the yield expected. How many do we expect? The number. So ovarian reserve is the quantity. This you have to know. It is the quantity. It is not the quality. I'm repeating, it is not the quality. There is no way we can know the quality of an egg. Actually, there is no way at all. This I'm going to prove today. We have, I won't prove anything today, but I'll give you literature which will prove it that it doesn't occur that way. When we talk about ovarian reserve, we talk about the quantity or the number, but not the quality. What is ovarian response? Ovarian response is actual yield post-ovulation induction. After we have done some stimulation, how many eggs or follicles we get, which can give us an egg, is the ovarian response. So ovarian response can be good, bad. Sometimes the MH may be high, but the response may be poor. It's a pretty complicated stuff we have there, but we have to know that ovarian reserve testing is the quantity, but not the quality. This is one thing you have to know. So let's look at an egg. Let's take an egg and try to break the shell and see what lies inside an egg and how all these eggs, they talk to each other. So that's the way it goes when we start talking to a woman when she comes to us and we want to access her ovarian reserve testing. And actually, we are always looking for a golden egg. A golden egg in a woman. A golden egg in a woman is costing somewhere around 15,000 rupees in Indian currencies. This is what we look at when we are doing an IVF or an IUI, and I prove it by saying that the average price of an IVF cycle is 1.5 lakhs, and we expect around 8 to 10 eggs in a woman. So it's around 15,000 rupees per an egg. And in case we look at an IUI cycle will cost us, in terms of getting one good egg, is going to cost us around rupees 18 to 20,000 rupees, including all the hormones and everything. So we have to give respect to the egg, and we should be able to diagnose an egg and find a happy egg. So my job for you would be how to find out a happy egg amongst all the eggs. And for this, we're gonna go up and down. We'll talk about hormones, we'll talk about ovarian architecture, we'll talk about what we already know. We'll talk about forgetting certain concepts, and then we will build our concepts again. So what we normally see is FSH, AMH, Inhibin B, and estradiol. This is what is the normal pattern which we follow. And in this pattern, we always also add some hormones like P4. We add testosterone, we add TSH, and we add prolactin. This is a PRL. They are not part of the ovarian reserve testing, but we do add these many tests. But primarily, we are dealing with FSH, AMH, Inhibin B, estradiol, P4, and T. This is what Any person, anybody's reports I see, they have ordered for all these tests, and along with this, they also order for a test called AFC. Now, why I picked up this topic? Picking up this topic was not only to talk about testing a person, but simplifying it. Antral follicular count, the pricing will be somewhere in a good hospital will be around rupees 1,000. FSH, I will all say AMH is around rupees 1,000 again. Inhibin B is 1,000 again. Estradiol around 500, and FSH around 500. What we normally get is a package of all these tests, which costs around rupees 2,500 to all everywhere. The cheapest package is 2,500 with home collection. And in this, once we add AFC, this package costs somewhere around rupees 4,000. So we are spending 4,000 rupees on doing ovarian reserve testing for a person. This is what I want to drill into your mind. I will give you my ideas. I will take your ideas, and let's come to an answer what we should do. What we have learned till now are some things which are pretty simple. We know that as the age will advance, this purple thing, we have age here, and this is the quantity levels. So as we find that as the age will move from 20 to 50 years of age, our levels of FSH are gonna go high. So FSH rises with age. Levels of AMH, green, are gonna fall down. So AMH will fall down. Antral follicular count will be falling down. And in case we do ovarian reserve, in terms of quantity, it is gonna fall down. So what we learn, which I teach all my students and I talk to my colleagues, is that in case you look at an ovarian reserve, in case you look at it, this goes hands in hand with AMH. It goes hands in hand with AFC, hand in hand with Inhibin B, and it is inversely proportional to age and to FSH. In case you understand this equation, I think more than half of the battle is won. We have to see what connects with each other and which all tests, which all things they work together, which are complementary to each other. This is what we have to learn. And so before I move ahead, in case you look at the folliculogenesis, there are two types of follicles are present. One is the pre-antral follicles. We have to know that we have the pre-antral follicles, which are the primordial follicles, primary or secondary follicles. Then we have antral follicles, which can be early, late, or they can be a big Graafian follicle. So when we talk about ovarian reserve testing, we look at these things. So primordial follicle doesn't do much actually. The whole thing starts with primary and secondary follicles, which are pre-antral follicle. So we have an early pre-antral follicle and we have late or secondary pre-antral follicle. Antral means having some fluid inside. Then we have antral follicles, and antral follicles can again be of two types. They can be early, they can be late, or they can be primary, or they can be secondary. You must be wondering, why am I talking about such antral follicles? Are they important? Why am I talking about pre-antral follicles? But gentlemen, ladies, as we move ahead, you'll find that they are the most important part of our learning today. And this is why they're important. We have a primordial follicle, which actually doesn't do much, so we won't talk about it. I'm going to delete primordial follicles from here. We have primary and secondary pre-antral follicles. They are pre-antral follicles, means that they don't have any antrum here. Then we have antral follicles, which can be small, or they can be medium, or they can be primary and secondary. Then we have a Graafian follicle. So all these things, they release hormones depending upon their maturity. So AMH comes from where? AMH primarily comes from the pre-antral follicles and small antral follicles. All these things, they will release AMH. When we come to Inhibin B comes from the small antrum and antral follicles. And important here is that till the time the follicles are primary or secondary, they are pre-enteral or they are early enteral, they don't come under FSH. FSH doesn't have any role on them. So they are independent of FSH, but after that, FSH takes over in their growth. So we have pre-enteral phase and a enteral phase. So we have primary and secondary phase. This is the one, and early of the enteral phase, they'll give us Inhibin B, and then they will give us 𝐴MH, and later we start getting Inhibin B. So all these hormones are interrelated and they work in a complementary way. Now we're looking at the ovarian reserve. We find that ovarian reserve, the number of the ovarian, the number of the follicles in an ovary, that depends upon the age, and the number will fall down as the age is advancing. So what we find is that when you look at a person, when the ovarian reserve at birth can be in millions, it can be millions at the time of birth of a girl, but by the time she attains around 40 years of age, she'll have irregular cycles and the number of eggs are gonna fall down. This is what one message you have to take. And when the number of eggs are falling down, so would be their capacity to release hormones. So their capacity to make 𝐴MH and their capacity to make Inhibin B will also fall down. And this is what is primarily ovarian reserve testing. So when you look at it from a distance now, let's go back to our school days. A woman is born with around 2 million eggs. A girl has got around 2 million eggs, approximately. So the numbers vary from 2 to 3 million in each ovary. But by the time she touches, say 45, the number of eggs in her ovary are around 500. Now, this means that from 2 million to 500, all other eggs have disappeared. They've gone somewhere and they have undergone some sort of atresia. But the number of cycles a woman has in her life presently with say 2-child norm is around 400 to 500 only. So only 400 to 500 eggs are being ovulated. Rest all are going somewhere. We are losing them at some point of time. This is one concept you have to know. So there's a rapid atresia in a woman when she's aging, and the number of the eggs are falling down from few millions to around 500 by the time she enters perimenopausal age. That's around 45 years. Now, this is about the oocyte reserve. We can look at birth, the oocyte reserve is so high. At puberty, it's gonna become around 2.5 lakhs. And then at menopause, it will be somewhere less than 1,000. This is how the whole concept works. And we're going to talk about it today at length. So we find that the fertility rate in the woman will fall down. The red is the fertility rate. We find that the fertility rate is falling down. But we also find that abortion rate is going up. Now, quantity, when we talk about the quantity is the ovarian reserve. This is being seen by the 𝐴MH. So the number is falling down, but in case you look at the rate of abortion and we look at the rate that they don't get fertilized, whatever left are not getting fertilized, that all depends upon the quality. So quality will also fall down, and quality will lead to increased abortions, and quality will lead to reduced chance of conception. That's the role of the quality. So clinical issues, when we look at some young girls, they've got good ovarian reserve, and this is as we age, the ovarian reserve will fall down. And our aim is to, the whole of, when we do an ovarian reserve testing, our role is to find out that which all eggs are good. Are eggs good or eggs bad? We have to pick them up, and for that we carry out some sort of testing. And topic is important because that's the most critical topic when you talk about IVF and IUI in ART. So as far as possible, I'll hold on to my experience at many places, which is of around 15,000 OPUs, similar number of 𝐸Zs and embryology, which I also do, and large number of TBS ultrasounds. So I'll try to correlate everything and give you a ready-made answer, which will be very simple and help you in pricing also, because it is not right that we charge patient huge amount of money when we are carrying out their ovarian reserve testing. We have to know that ovarian reserve doesn't go by some numbers with age only. There can be multiple factors which will make the ovarian reserve fall down in a woman, and these factors can be multiple. A woman may have endometriosis, there can be some genetic disorders, cancer treatment, lifestyle disorders, which will lead to the ovarian reserve falling down very, very quickly. And such women may have a poor ovarian response or a diminished ovarian response, or they go into premature ovarian failure that is less than 40 years. So these things keeping in mind, we have to see what we can actually change, what we can alter. Some things we can't alter, some things we can alter. But we have to know that there can be patients without any ovarian function when they have a low egg reserve completely, and then there can be ovarian function is not happening properly, disordered. So here we have poor ovarian response due to advanced maternal age, some genetic abnormalities, and failed IVF cycles. It's all we have to keep in our mind. So now when we talk about doing ovarian reserve testing, it's something like this big menu. You pick up a plate and probably you will barely take 100 grams of food, and all the other food, I don't know what happens. It will be probably wasted, or it goes to some other party in some other lounge. So is it important? So now I begin my talk here for you today. I begin with an answer which I ask all of you. Please keep a hand on your heart and give me the answer. Is it right to take so much of food and then waste it? I feel more happiness in this. When you look at this child, he's got some spaghetti. Look, any child, one thing they actually love is pasta and spaghetti. That's the way they eat it. They're very happy in that. And we can actually see the happiness on their face. And the same concept we're going to apply today to our ovarian reserve testing as we move ahead. So let's be like a child again. Let's try to read a lot of literature and get an answer so that we are able to do good job and save patients money, still get good answer from doing our ovarian reserve testing. So just pick up something which is important and leave everything rest. That's the point I'm gonna bring back to your mind today. So like a child sitting with a small teddy bear is the happiest. He doesn't need a lot of toys. He's very happy. He'll get a teddy on his birthday, and for next 5 years he's happy with that teddy, with that small teddy. So keeping that in mind, let's build up the topic now. Aware that the number of follicles, primordial follicles in the woman, they will fall down as a child takes birth. The child has taken birth here. They'll start falling down, and as she goes towards the puberty, the number of follicles may be around 3 lakhs, and as she goes towards the her menopause, she crosses 38 years of age, the number of eggs will fall down by a large number. So the supply of the eggs, the manufacturing of the eggs in the body, which number is already fixed in a woman, they will become less as the woman crosses 38 years of age, and as she crosses 38 to more than 40, her ovarian reserve is gonna fall down. This is one thing which we have to know. So the age in the woman is important, and the number will fall down as she enters the menopause. This is one chart. I think all of you should spend half a minute and try to understand this chart here. The chart says that as the age is advancing, as the age is advancing, egg reserve is falling down, and we have already spoken that egg reserve will come down to around 1000 by 50 years of age, and by 40 it is around 8000. This is the numbers which we keep in our mind when we counsel the people. And monthly birth rate, now look at this number, the monthly birth rate, the way it is falling down, you can see from say 20% is gonna fall down to nearly 1 or 2%, which it touches 42, 43 years of age, and may become 0 at 51 years of age. So as the age advances, there's an end of fertility. the fertility is going to fall down, and as the fertility is falling down, so are the number of eggs. So when we start with 20 million eggs, look at the number, it's 20 million eggs. Sometimes we always wonder that how many zeros are in a million. That's the number of eggs a woman has, and by the time she touches 38, the number is going to fall down to around 8,000 to 10,000, and it'll keep falling down thereafter. And then comes the end point where we don't know what to do. And we nowadays are at a cusp, because in average age where I get my OPD at Birla Fertility and IVF is 38 years. I barely get any woman less than 38 years of age. That makes the whole process very, very challenging for all of us. And we have to understand that we should be now ready. Ladies and gentlemen, we should be now ready to handle one egg, a golden egg, or a egg which is actually not a good quality, maybe made of a copper, and try to get them a pregnancy. So things are changing, and so we have to adapt to the changing scenario. Gone are the days when pregnancies, we are very happy to get a pregnancy in a woman who is around 25 to 35 years of age. These women will, by any way, they'll become pregnant. They don't have any problem at all. Problem comes after the age group of 38 years. When the pregnancy rate falls down drastically, and here comes the question of our doing ovarian reserve testing. And so here I am, and I'm going to build up the topic. With this background, I move on to the topic for today in a more aggressive way. So I'll take you to this article of 2020. And as I've promised you before, after the lecture is over, all these articles are being sent to you in a group. They'll come to your group. So need not worry. So we have to know that the number of eggs, they peak in utero. They start stabilizing at birth, and finally they start getting atresia. And only 400 of them, they are properly used. Rest, all of them, they undergo atresia. Why they undergo atresia, why it happens, this is beyond my comprehension at this point of time. But we know that reproductive and ovarian senescence occurs with depletion of the number of oocytes or ovarian reserve. I will repeat this thing again, gentlemen, ladies, that ovarian reserve is the number. It is not the quality. It is not the quality, it is the number. So as a woman is aging, we always find that they have a lower ovarian reserve. This we have already seen. And we have to learn to measure the ovarian reserve by doing some amount of testing. And these testings can be at a hormonal level or an ultrasound level. And I've told you, an average amount of money, which always touches my heart, which we do to assess the ovarian testing in a woman, is around 2,500 plus 1,000 rupees. That's a minimum we charge her. Somewhere it touches around rupees 5,000 or say 4,500 rupees. It's a huge amount. Let's see how we can avoid spending so much of money and still get good outcome. That will be the motto of my talk. So we're going to review the evidence. We're going to review a lot of things as we move ahead. So I'm going to take a few important queries for you all. What is ovarian reserve? So normally people ask, ovarian reserve kya hota hai? What is ovarian reserve? It's a number. Let's talk about it more as we move ahead. How do we measure an ovarian reserve? हम कैसे जाने कि हमारे में कितना रिजर्व है? This is very important topic for all of us to know how do we measure it? We have it, but how do we measure it? So it is not like we have a mobile phone and we put we have a banker code, we put it and we come to know how much is our balance, or we get every month we get an SMS message or a WhatsApp message saying how much money we have in an account. We get a message, or in case the money is leaving our account, we get a message. But this thing doesn't happen in the woman. It doesn't happen in the men also. So here we have to learn how to measure it from outside with a clinical outcome. Recording a number won't give us any help. So we have to record a number with a good clinical outcome. So keeping that in mind, one more good question comes to our mind is that we have a woman who has got unproven fertility, meaning a girl who is say 25 years of age, who's working in an IT segment or a BPO, or she may be an entrepreneur having her own work. Now she comes to us and says, doctor, can you tell me would I be fertile? When I get married, would I be fertile? Or how fertile I am now? Or how long can I delay my fertility? Because in her mind, she has got the concept of going in for oocyte freezing. So what do? We do certain tests for her and tell her, okay, we do this, we do this, we do this, and then we give her some sort of a fertility index. We say you are fertile or you're borderline or you'll have some other problems. So we give her some gyan, which is actually not right. So important query is that can we do fertility mapping for a young girl? This is important. Second is we get a woman who has got infertility. When a woman has got infertility, is there any method by telling her that since she has got infertility, can we really help her and how do we help her? Are doing ORT is going to tell us that she'll be fertile? This is one. So we had two different populations. Population one was the young girl who's far away from marriage. Population two is a girl who's married but wants to know her fertility. Then do we have ovarian reserve markers which will tell us after doing IUI, she'll become pregnant? So in case you have two categories of people, two categories or three categories of girls, can we tell this girl is going to become pregnant with an IUI or with an IVF or with an IVF? So this is after IVF or an IUI. Do we know? Do we have any method to tell people that in case we work on you, you may get ovarian hyperstimulation? Are there any ovarian reserve markers available for that? And in some women, we try everything. They've got a poor ovarian response. How do we manage it? Pretty complex situation everywhere. And we do what we have been told to do by our teachers. And important is that we should know which patient should undergo ovarian reserve testing and what type of testing should be done. This is important. This will be the prologue of my lecture. So ovarian reserve is defined as a number of oocytes remaining in the ovary. That is the oocyte quantity, oocyte number. Ovarian reserve, as I've told you, is the oocyte number. And we have also said that there's a variation in the AMH, there's a variation in the AFC, and a lot of things happen in the body which is not static in the woman. So we have to draw a balance amongst them. So clinically, the most important thing which gives us some idea about the woman's physiology is the age. In case, always talk about her age and her menstrual cycle. In case her age and menstrual cycle are working well, we can be sure that this woman is doing well. Then we have some biochemical factors. We have FSH, E2, AMH, Inhibin B. Then we have AFC, ovarian volume, ovarian blood flow. We have got clomiphene citrate challenge test. We have a lot of things which we carry out. What I want to learn today is that what is important. Should we look at all these things? Now, all the companies, they give us a package. They give us a package and we buy that package for say rupees 2,500 or 3,000 and do a lot of tests for the woman. Are they beneficial? This is what we want to learn today. So what we find is that in case we ask a clinical question to ourselves, that in case we are trying to get we ask a clinical question about evaluating the ovarian reserve, postmenopausal status, to distinguish PCOS from hypo, we find that only few tests they work, and these tests which are working are primarily AFC and AMH. They are the ones which are working well. Rest all don't give us much of idea. So in case you want to go in for ovarian reserve testing, our focus should be on AFC and AMH, but we'll talk about some other tests also. And these tests which we have in front of us are basal, serum FSH, and E2. Now, for all our alumni, we have spoken around for 4 to 6 hours on routine menstrual cycle, which is very important for us to know. But we have to know that whenever the cycles they initiate on day 1 or day 2, that's a time when the levels of E2 are low. So at that time, levels of E2 are always low. When the E2 is low, it will bring FSH, and then FSH will correct the levels of E2. So always to start with, E2 is inversely proportional to FSH. And when FSH comes, it will increase the levels of E2. And when E2 levels go high, then the FSH values will change, and E2 will bring LH, and then LH brings P4. That's the way the whole equation works, and we have spoken about it multiple number of times. So we've got some fixed numbers in our mind, which are on day 2. On day 2, we should know what are the numbers which are available to us, and we find that these numbers should be done on as early as possible in a cycle. So we have a basal test called serum FSH, and we also carry out estradiol. Remember that these both are inversely proportional to each other, and they both correct each other at some point of time. So in case we really want to do an ovarian testing, we have to know that these are not very sensitive tests. So both FSH and E2 will have a lot of intercycle variability, and with this variability, we don't get good outcome. The outcome is not good. So the outcome is not good. So we don't tell people to go in for E2 and FSH anymore when we want to start an IVF cycle for the couple. But this is not a right test. So what happens is that in case a person has got a diminished ovarian reserve, the levels of E2 starts going up very early. And since E2 goes very early, the E2 will be opposing FSH release. So you will find that FSH values are normal, but E2 is high. And we always get confused what is happening to our patient. Just remember that with this sort of a conflict between E2 and FSH values, we don't suggest people to carry out E2 or FSH in any IVF or IUI cycles. Then the other test which we get, which we do is anti-Mullerian hormone. And as I've told you before, we have a look at two hormones. One is AMH, other is Inhibin B. The AMH works at the level of pre-enteral and pre-enteral small and large, and then small enteral. So pre-enteral small and large and small enteral. This you have to remember. So these are the follicles which are releasing AMH, and this is independent of FSH. Now when we go to Inhibin B comes from enteral follicles only, and this phase is also being controlled by FSH. So we'll always find here that Inhibin B, AMH does not have good correlation with the FSH, but Inhibin B is always inversely proportional to FSH, because Inhibin B, whenever Inhibin B will be high, FSH will be low.
Your available balance is insufficient to make this SD call. Please recharge with ISD pack or top-up voucher. Make this call.
So we find that these two are interrelated. So whenever we're talking about AMH and FSH, AMH and Inhibin B. Inhibin B is inversely proportional to FSH, and AMH is independent of FSH. This is what you have to know. Now we go to. Could someone mute her, please? So again, a similar picture. We'll talk about AMH, AFC, and FSH. These are the common markers we have: AMH, AFC, FSH, and Inhibin B. Remember that we can only look at the AFC when we can see such entrams. So these entrams are normally seen from day 2 or day 3. So looking at entram is seen in a small enteral follicle onwards, and after that the entram is seen, cavity keeps becoming bigger. But small pre-enteral and large pre-enteral means that there is no entram, so they cannot be seen on an ultrasound. This you have to remember. So there's a big correlation between all the things, and we have to pick up the right tests. But out of all these tests, what we have found is that AMH and AFC, they very well correlate, and FSH and Inhibin B they have intercycle variability, so we don't talk about them. Estradiol has also got intercycle variability. So estradiol again we don't talk about. So estradiol, FSH, and Inhibin B are not the good test for us. The right tests for us are AMH and AFC, because they don't have any intercycle variability. So in terms of responsiveness, how an ovary will respond, we come to know by looking at the pre-enteral follicles or early enteral follicles, which we see on day 2 of the cycles. And I'm sure you'll be aware that when you look at the follicle size should be between 2 and 9 millimeter. These are the small enteral follicles. So how do we look at the AMH now? When we look at the AMH, we found that it's pretty conflicting. A lot of you in the class talk to us and they want to know about which is the right method to do AMH. Just remember that there were 3 methods of doing AMH when it all started. So we had a kit called DSL. Then we had this from an American company. We had a kit called Immunotech. We called it IoT. This happened a couple of decades back. And then after this, these kits were always, this was from France, Immunotech, it's from USA. And they were giving us conflicting reports. So there's a company called Beckman-Coulter. They bought the companies. Beckman-Coulter is a very famous company. And they developed a kit called Generation 2 ELISA. And then they stabilized all the kits. And nowadays we are primarily going by Generation 2 ELISA kit. This is important for us to know. And Generation 2 ELISA kit, as it is coming to the market, it is being followed by 14 other kits which are available. But nowadays, when we look at the outcome, we depend as much as possible on a Generation 2 ELISA kit, which is by the Beckman-Coulter company. So this is a journey from DSL to IoT. So we talk about multiple assays which we have, and sometimes you get confused how to store AMH. Do we store AMH value, the serum sample at -4 degrees centigrade, -8 degrees centigrade, -80 degrees centigrade, which people talk to me in the class? Remember, they don't make much of difference. They won't make much of a difference. There are enough studies that -8 and 80 are equally good. How do we convert? Sometimes the values are in picomoles per liter, sometimes the values are in nanograms per ml or liter. What to do? Just remember that to convert nanograms into picomoles, which is multiplied by 7.18. This is you have to know. Multiplying them will be giving you the right numbers, and this is a very safe method of doing it. But in case you have some more issues, you can always go to the AMH calendar. This is the AMH calculator available on the internet. You can download this, and always you can convert AMH to picomoles. But nowadays all the values which we get are in nanograms only. So this is a very safe thing which we are doing now. So these are the normal values of AMH, where we talk about the normality, abnormality. The best part is that none of these values till here tells us how the lady is gonna respond. There are multiple studies which have been done in the world. I'm not quoting you studies, but I'll be sending you the studies today when after the talk is over. AMH may be 3 to 6 or AMH may be 0.3 to 0.6. The outcome cannot be predicted. That's the most beautiful part. I also learned that we cannot predict the outcome in terms of quality of the eggs. Numbers may be less, but the quality may be good. And more than that, there are multiple other factors which help a woman to conceive. So this we have to keep in our mind. And we have to know that the serum AMH is being produced by the granulosa cell layer. And when we have a primordial follicle, it has a single layer of cells which are flattened cells around it. This is the primordial follicle. Then we have the primary follicle, and we have the secondary follicle, and they start developing, it starts becoming cuboidal. And then they start making multiple layers. This is the secondary follicle, and then secondary oocyte, and then they start making a small antrum inside. This is the antrum, which has got fluid inside the cavity. This is the way the things start moving, and we have to know that we get AMH from here till early antrum. This is one key point you all have to know. And you have to also know that the women who are on oral contraceptives, in those women, we should not be doing AMH. AMH can be done on any day of the periods, but now there are some guidelines which say that we should do it between day 2 and day 3. This time it is very safe to do it, because as the follicles are growing, the values may go high. Luteal phase values can be different in a woman. So the safest method is that do it do it between day 2 and day 3. That's the day when we can also carry out their enteral follicular count assessment. So the best method is AMH. This is very sensitive and best method, and this gets to be affected much earlier than E2 and FSH. So I think in case we have to pick up a test, out of all the tests, we'll pick up a test called AMH here. This is very important. So enteral follicular count and ovarian volume, these are the very important things which we have to follow. And as I've told you that age is inversely proportional to the values of AFC and the values of AMH. This is a formula I tell to all, but can be challenging. Yesterday I had a lady who came to me from Iraq, and this woman had age of 47 years. I could get around enteral follicular count of 12 in her, and AMH was 1.82. So variations can be there, but overall you find that when we look at the woman, the age is inversely proportional to the AFC and AMH values. And when we look at the count, an average count in a woman should be, enteral follicular count should be more than 6 to 8. That's the AFC in the woman, enteral follicular count. In the ovaries, this should be the values which we should be finding. And when we get such findings, we are actually very happy. This is an okay thing. But as the age becomes more than 38 years, we will find that the values of AFC are going to fall down. And AFC is enteral follicular count. This we only do after the follicles have developed a small antrum inside, and somewhere we'll have an oocyte lying here.